On behalf of the Patient Safety Authority, I'd like to welcome you to this web conference titled, Treating Hyperkalemia, Avoid Additional Harm When Using Insulin and Dextrose. My name is Megan Shetterly, and I'll be your moderator for this program. Now I'd like to introduce our speaker for the webinar, Matthew Grissinger, serves as the Director of Error Reporting Programs at ISMP and Manager of Medication Safety Analysis for the Pennsylvania Patient Safety Authority. He has published numerous articles in the pharmacy literature, including regular columns in P&T and the PSA Advisory. And he is journal reviewer for the Joint Commission Journal on Quality and Patient Safety, Pharmacoepidemiology and Drug Safety, Therapeutic Advances in Drug Safety, and Annals of Internal Medicine. Mr. Grissinger received a BS in Pharmacy from the Philadelphia College of Pharmacy and Science, and is fellow of the Institute for Safe Medication Practices, as well as the American Society of Consultant Pharmacists. So Matt, now I'll turn the program over to you.
Thanks, Megan, and good afternoon, everyone. And thank you for dialing in for today's webinar. Today we're talking about an advisory that just came out in September, and I'll just go back to the title slide here. So we're talking about treating hyperkalemia and avoiding harm when treating that with insulin and dextrose. And this whole topic gained my interest a little while ago when we were made aware of a death in an organization with the treating. It came about through the treating of someone with hyperkalemia, and a long story short, with giving insulin, because when you give insulin for hyperkalemia, well, as we'll learn later, it's a very, very small dose given IV. And in this situation, long story short, the nurse accidentally gave 3 mLs of insulin, IV push, instead of 10 units. And again, there are a lot of contributing factors to this, which I can go over a little bit later. But that kind of case woke me up to the challenges that we have with, really at the end of the day, giving insulin in that small dose in that route for this condition. So as a backdrop, we're going to talk about some common types of errors that have been reported to the authority that occurred when treating hyperkalemia throughout the medication use process. And we'll talk about contributing factors that were associated with that, as well as strategies. But we'll also start off by just kind of talking about what is hyperkalemia and where this all starts. So what is hyperkalemia, what causes it, and our goals of therapy. So hope everyone's ready for their old physiology lessons here. So we'll touch a little bit about physiology stuff here. So as you may be aware, about 90% of the body's potassium is located inside your cells and the other 2% outside in your bloodstream. Okay, so what happens with hyperkalemia is obviously the potassium in the bloodstream is higher than normal for a lot of variety of reasons. Keep in mind, as stated in the second bullet, potassium plays a big role in conduction in regards to your muscles. So that could be muscles from the GI tract to your heart to anything in your body. And so having that right amount of potassium in the bloodstream really has an impact on the resting membrane potential. And any disturbances here can obviously have an impact on cardiac function and neuromuscular function. Serious life-threatening hyperkalemia is defined as in that third bullet of being 5 milliequivalents per liter, is what you'll see. And the effects of having too much potassium in your bloodstream really comes down to cardiac issues, because it will actually have an impact of the sodium, potassium, ATP, ACE, and what goes on with the contractility of your heart. So because of the high potassium, it may have an impact on the T waves you'll see in the EKG, prolonged PR intervals, et cetera, and all these conditions you see. But simply speaking, it can lead to bradyarrhythmias, and even asystole, and all those other cardiac issues. But the key thing is what causes it. And there's a lot of things that can cause hyperkalemia. And keep in mind with this presentation today, we're going down a path of using insulin and dextrose to treat hyperkalemia. But it's important to understand now that is a very temporary fix. It's a very important fix in the very beginning stages of hyperkalemia, but it's not the permanent fix. And more importantly, it does not cure what caused the high potassium level in the first place. So a couple of things to keep in mind in the first bullet. And number one, 80% of potassium is excreted renally. So therefore, anyone with any type of kidney disease could have high potassium levels. So that could be one starting point. It's probably the most common starting point for high potassium levels. And of course, there's other causes as well. We could have increased ingestion, whether it's medically with potassium tablets, IVs, or eating potassium-rich foods is one example. A bunch of other iatrogenic causes or other things that causes potassium to shift from inside the cell to outside the cell. And that could be issues where you have some tissue damage, like people get burned, have trauma, and you picture your cells breaking down. So when cells break down, potassium gets released from inside the cell out to your bloodstream. So that could be one thing. Or any type of acidosis states, or states where you have even like around diabetes. If you don't have enough insulin, that may also lead to hyperkalemia. Hence, why I use insulin as a treatment to lower levels, and how that works is you're going to give insulin, and that's going to promote the intake of potassium from outside the cell back into the cell again. Also, some just other things to throw in there, other medication-related causes. Keep in mind drugs like ACE inhibitors, angiotensin receptor blocker drugs, maybe even some nonsteroidals and a potassium-sparing diuretic like spironolactone also may have an impact. So you can keep this in mind even when we get through this presentation, that you still may have to evaluate what caused the problem in the first place. Now, another thing to consider too with elevated levels is here is that it could be because of actually a pseudo-hyperkalemia for a variety of reasons, and predominantly how you get the blood sample. And I think many people on the phone have lived that, right? And we'll go over some of those issues later. But some of them can include that your blood sample hemolyzed, giving you a false high level of potassium in the blood sample, not in the person's body. Or lastly, where was the specimen drawn? So you have to keep an eye on what IVs are being hung at the time, and whether the site that you're drawing the blood specimen out of is not also the same line as someone's getting E5.5 of potassium in an IV bag, as another example. So obviously, the goal for treating hyperkalemia too is, number one, take care of the heart. So if you need to stabilize the cardiac or the heart in any way, you may have to use IV calcium, which will help shift the potassium back into the cell and also enhance potassium elimination. But in addition is, again, using a shorter acting insulin, usually given with dextrose, because obviously if you're given insulin, you're going to lower someone's blood sugar. Now, think about the people who aren't diabetic. And you give them insulin, surprisingly, right, their blood sugar will go below normal. Therefore, you're giving dextrose to combat hypoglycemia from giving the insulin, and the insulin is given to increase the importation of, again, potassium back into the cell. But again, really important right here at the bottom. This redistribution, with the insulin causing the potassium to go back in the cell, is temporary. It's almost like kind of not hiding the symptom, but it's just momentarily shifting things back into the cell until we address the issue of the high potassium in the first place. So that's a very important consideration to keep in mind. Okay, next slide. Slide 7. So now what's the literature say about treating this? And here's where it gets really tricky, because one thing that really surprised me is when you look in the literature for treating hyperkalemia, if I can say there's no standardization of how this should be done. I'm amazed at the variety of things people say in the literature. And I have some examples on my other monitor here I'll read off in a second. So let's start with the American Heart Association, the AHA here. They recommend treating this hyperkalemia for people who have severe cardiotoxicity or cardiac arrest to give 10 units of regular insulin, IV, mixed with dextrose. And this kind of throws me off. I'm somewhat leery about the word mixed here, but that's what they come out and specifically say, that theirs is mixed. Now, let me read some other examples I have here. So, for example, the Journal American Family Physician stated to give regular insulin IV with 50 mLs of D50, while the United Kingdom's Renal Association guidelines say to give an IV infusion of insulin instead. Another example, Critical Care Medicine Journal said to give an IV dose of 10 units of regular insulin as a bolus, along with 25 grams of 50% dextrose. And the list goes on and on. So Well, so sad to say, if you don't have guidelines that are standardized for this, and you will look up in the literature, and by the way, the references are listed at the end of the slide decks. When you see numbers after any statements here, the references are at the end to help you out here. But you see the variability again. Part of the problem here is the fact that people list different types of insulins for this. So some say to use rapid-acting insulin, and some are saying to use regular insulin. And I would even debate how up-to-date the ones that say regular insulin are. If you think about this, the real rapid-acting insulins, like the Novolog and Humalogs, have a quick onset, very short duration. Next in line, kinetically, the regular, which has a little bit slower onset, unless you're given an IV for this, but it'll last a little bit longer too. Hence, potentially longer period of hypoglycemia. That we'll come back to that topic. So just the type of insulin makes a difference here. Also, there's differences in literature about how much dextrose to give as well. But you'll see here that at the bottom just other examples of how the state to give insulin here. Next slide, here it is about the dextrose. So yeah, there's also inconsistency about how much dextrose to give. And look at the ranges here. So definitely variability as well. I will also, to jump ahead a little bit, tell you by reading some of these event descriptions that it's pretty clear that organizations did not have any type of standardized guideline how to do this. Judging by even a wider variety of insulin, how it was prescribed, or prescribed wrong, let alone administered wrong, and a lot of times because people rarely do this treatment to treat hyperkalemia with insulin IV push. Now, you'll see in a second bullet, even though if you're using dextrose, hypoglycemia can still occur. And again, I think it's going to really come down to a lot of things, especially the type of insulin that you use and how much dextrose you give. So just keep in mind, it's not as simple as 10 units IV push of rapid-acting insulin, give dextrose, and you're done. You're still going to have to monitor the hypoglycemia after the dextrose is done. Now, obviously, the potential for error and harm from this condition can really be variable, right? Because it depends, A, severity of the condition that caused the problem, right? Someone has severe renal insufficiency, it can be a different story than someone who has maybe moderate or not even any renal insufficiency at all. How urgent the situation, to the point where we're getting cardiac arrest or not. And really, the EKG is going to really be the indicator to tell you we got to really get moving on treating this condition. But the variability in the dosage regimens in the literature and the type of insulins prescribed make the potential for error even greater in my mind because of that lack of one standard approach to do this. Okay, so that's the background. So let's talk about this analysis, how this all came about. So I actually have this slide here just to explain how we look for these events, because you can imagine trying to search for these events in hundreds of thousands, even millions of event reports in Pennsylvania that we have to date. So we had to do some free text searching, and people have used other phrases, natural language processing, etc. Essentially, all we did was search descriptive fields like the event description, and eventually the drug name fields. So in the event description here, what we searched for were terms that relate to this: hyperkalemia, high potassium levels. Now, think about how many different ways someone could write this in an event description in an AR report. And the shortcuts people take, right? One thing, just like people don't write hyperkalemia in an AR report. Or spelled correctly either. So what you see here is I just do this for FYI, because I think this is a tool, this is a way of looking at things that you may want to consider down the road with a good electronic health record, and to search for issues in your database by using this searching methodology. So all these are just samples of phrases that we look for the terms up here. So for example, that's hyper-K for hyperkalemia, potassium abbreviated, elevated space potassium, high potassium. And I lost track of how many terms we used, but it was well over a dozen different terms to try to capture high potassium levels. In addition, at least for the medication error and the adverse drug reaction fields, we also search the drug name fields for either types of insulins as well as other things that treat hyperkalemia like electrolyte and polystyrene as an example. So that was the starting point, to at least narrow down the reports to a certain number. Okay, so after doing that, what we come up with is, you'll see on the slide here, a total of 1,367 reports. Now, key thing to keep in mind is, clearly not all these reports are going to be applicable. People can mention someone had a high potassium level, but the event they're reporting is something totally unrelated to treating hyperkalemia. So therefore, this meant that we had to, actually, let me correct myself, we had 1,565 events. Of those, this 1,367 events over here were eliminated because they were not what we were looking for. We were looking specifically for errors in the treating of hyperkalemia with dextrose and insulin. So when all the math was done, we had 196 events. So, and again, we were looking for events, reports that they included insulin for treating hyperkalemia and an error or an adverse drug event occurred. So you can imagine, and I have to call out too right now, Asystole Laws, who actually did the advisory for us. She was a fellow at ISMP and did all the analysis of this. So she had to read through everyone, 1,500 reports, to eventually throw out over 1,300 of them. So you can imagine how much time and work that took to read that many error reports to get to where we're at today. Of course, reporters assign harm scores, you're used to that, and event types. I will say we searched every type of event, so we did not limit this to just medication errors and adverse drug reaction. We searched the entire database for those terms to make sure we really try to capture things, because people report things and how they see it, and what you may call a medication error, they may call a complication of procedure as an example. So that way we try to capture as much as we can. So one thing we did in the second bullet here was we kind of combined three event types. That is dose omission, wrong time, and a prescription refill delayed under the medication error piece, and just call them all dose delayed. From our experience when we read these event types, inevitably there's a lot of overlap in what they mean to people, so we just call them all a dose was delayed to simplify this analysis. We also want to just track how many times people mentioned that the patient became hypoglycemic, and the key word is mentioned. So when we come up with numbers later, just because it didn't appear as a number doesn't mean that person didn't have hypoglycemia. It's just that it was not stated in the event description of the report. So that's a key caveat. Lastly, based on ADA guidelines, the American Diabetes Association, we considered 54 milligrams per deciliter as clinically significant based on their guidelines. And we'll come back to that in a couple of slides here. So let's go into analysis. Let's see what came out of this. Number one, this is just a screenshot from the advisory of how it was categorized by reporters in Pennsylvania. So understandably, most of them were medication errors. You'll see here in the dark blue, at two-thirds of the events here were classified as medication error. But you'll see error-related procedure was second at 13%. Complication procedures, ADRs, others, and the 1% here was categorized as a fall. So again, beauty is in the eye of the beholder. It depends how people categorized it, but they also gave us reason and really proved why we had to search everything and not just medication error as a field here. Okay, so next slide. So next slide is just a simple slide. How were these categorized as in regards to harm scores? According to the PACER's harm index, which is kind of based on the NCC MARP index. And you'll see the vast majority of them here did not cause harm according to the reporter, and that number ends up being about 96% of the reports did not cause harm, while there's 4% here that were serious events, the 8 number here. So you see also, of all the events, 90% of these errors actually reached the patient. So it's important to understand, compared to the close calls at 10% here versus all the ones that reached the patient here, which again, 90%, which is a pretty high number, everyone, of incidents that actually reached the patient, it just did not cause harm in the eye of the reporter. Okay, some other results here. Real easy stuff here. So top 3 care areas cited in the reports, overwhelmingly ED here, by the way. And we'll come back to that, especially with communication comes into play with EDs. Med-surg as well, and we'll talk about some delays here where issues may have been identified in the med-surg area, followed by telemetry, which kind of makes sense because that's what will be monitored. The most common types of errors submitted in here were doses being delayed, which we talked earlier about that combination of omissions, prescription refill delays, and wrong time events, followed by wrong routes, followed by overdoses, which represent almost over 10% of the events. So let's talk about delayed doses. So there are a couple reasons that were stated in the event descriptions why there may have been a delay in dose. One caveat I'll explain again is it applies to all the data here. While there were 42 of these, you'll see that all the percents on this page probably won't add up to the full 42 reports because the event descriptions just didn't tell us enough, everyone. So it's kind of important for you at your organization and really for us at the authority is that event description is where all the meat is. And so if it's not an event description, we don't know what happened. And that really came out in this analysis. So some reasons for delay. Primary reason that reading event descriptions, this happened over a third of the time, was insulin was ordered but wasn't given prior to transferring a patient to another unit. And most of the time, most of those 15 reports implicated the EED. So it was ordered in the EED, patient was transferred to another unit, but I know you may find it surprising, but there is a miscommunication between the EED and the floor of what got given when. And no different, everyone, than all the other challenges you're having, figuring out what was given in the ED. This, I think, is a lot bigger problem because clearly they identified hyperkalemia in the ED, but yet nothing was started. And then they were transferred. So that presents a lot of problems, everyone, especially on the degree of how hyperkalemic they are. Second common issue that was stated here was people were ordered IV insulin, because it has to be given IV, not sub-Q, but where the patient resided, like a med-surg floor, is not equipped to handle insulin infusions. So therefore, they have to be transferred, right? So that's another thing to consider is that a couple of these times it is specifically noted that IV insulin was ordered, but it's not allowed to be given because they weren't in a proper unit like a telemetry unit or an ICU or somewhere they can be actually monitored for the cardiac effects of the hyperkalemia and the administration of IV insulin. And lastly, another thing mentioned a couple of times was the fact that the medication just wasn't available at all. Here's just one case example below here about a transfer issue. That's what is italicized. That's actually a report in Pennsylvania that's been de-identified. Critical potassium level 7.2, non-hemolyzed, called to the attending. Physician ordered IV insulin, but was unable to safely give on a general medicine floor. Spoke to pharmacist and supervisor, told the patient had to be transferred to the cardiac floor, and then it was taken care of. But this is a pretty simple or pretty obvious issue here. The key thing is, the minute someone gets a potassium level of something this high, what's your organization's response? And that's the thing to think about is knowing that the delays here, and we'll come back to this, are a major problem here. We need to address how you handle these reports up front of the high potassium levels. Second most common thing is incorrect route. And this is really kind of obvious to my mind. So the second most common thing, you do see, though, that more than half are administration-related, but over a quarter are also prescribing issues as well. So it comes to play both ways. And so we see a variety of things. For example, the order was for IV insulin, but due to confirmation bias and due to the fact that we literally always give insulin from a syringe sub-Q, the fact that once in a blue moon it's ordered IV just throws people off. And I can tell you, reading event descriptions, that they would come out and say, well, gee, the nurse isn't used to giving this IV. They never saw us before. It must be wrong, right? So keep that in mind because the problem with this scenario is how rarely it happens, right? So if it happens once in a blue moon, yeah, you're going to see these misadministrations because 99.9% of the time you're giving it sub-Q. Here's the one time you're giving an IV push, the one and only time probably. Second thing here was the order entry issues where just using a CPOE system, it was entered as sub-Q instead of IV. And I would even build the case, I'm going to read into this on my own here. So what were the pre-printed order sets look like here? I mean, people should have a treating hyperkalemia order set, and that should be built into the system. So the fact that the route was entered wrong, speaking loud to me that there's not a pre-built order set for this. And hence, having one now, you can see the type of errors it may prevent. And there are also situations where people had orders for sub-Q that's actually given IV as well. But I think, at least administration-wise, what really struck me in reading the reports was just that people just weren't used to doing it. And, you know, when you're done here, you can go home and educate all the staff in your hospital about this webinar and how to handle hyperkalemia. Keep in mind, it happens once in a while. So even a little simulation may help here so people kind of go through the mechanisms of what's going to happen here. Again, when you use something very rarely, clearly human error is going to creep into this. Okay, third most common type of issue was a wrong dose overdose. So for the most part, reading event descriptions, predominantly administration was a third of the time. How it was prepared, though, was over a quarter of the time, as well as prescribing it was an issue. Here's a good example here below. A patient with potassium of 6.9, orders received for albuterol, IV regular insulin, E50, 25 grams, sodium bicarb. The nurse told the charge nurse he was unfamiliar with giving these meds. The insulin was not drawn up in an insulin syringe. It was drawn up in a 1 ml syringe. The insulin syringes used in this facility are not compatible with IV push. The patient became obviously hypoglycemic because their blood sugar was 20. And this is the whole thing here. And we're going to talk about the syringe issue later on. It was drawn up in a 1 ml syringe. Because remember, insulin syringes have needles on them. Okay? But if you're in a needleless environment and your IV ports are needleless ports, that insulin syringe is no good for you. In fact, that breeds the at-risk behavior of drawing it up into an insulin syringe and then get transferred to an IV syringe on the floor. You know, that case I spoke earlier, one of the contributing factors was, and the leaders in the organization didn't realize this, but there was a back order on syringes, Lorlock insulin syringes, so they had to go back to using regular insulin syringes with needles. So the nurses had to drop 10 units in an insulin syringe, transfer it to a 3 ml syringe, and then dilute it down with saline and give 3 mLs IV push. That's the reason why that nurse had a 3 ml syringe in her hand, and with obviously the slip of having the insulin vial in her hand, and probably as a habit, drawing up a whole vial, right? That's how some of that precipitated. Okay, so now let's talk about hypoglycemia. How many times hypoglycemia is mentioned in these reports? So, of all the 198 reports, over a quarter of them, almost 29%, mentioned hypoglycemia or blood sugar less than 70. So let me clarify again. This does not mean that 71.2% of the reports, patients did not get hypoglycemia. We're just saying it wasn't mentioned. So this number could go higher. I'm not saying it's 100%. I couldn't even guess what that number is. But that's still a decent number, considering that's probably not all of them. So that is the minimal number is 20%. Of that 57 that were hypoglycemic, let's see how many were below 54. 70% of them were below 54, everyone, which is this part right here. And you see how many here, the 15 or 26%, had blood sugars less than 30. So that's pretty low. Okay, so other issues with hypoglycemia. 9 of the cases mention specific areas with dextrose, where the issue was the dextrose administration was delayed. Now, obviously not the insulin, but the dextrose was. Unfortunately, we don't really know why for all those cases. One of the reasons was the order entry piece here, because it sounds simply very simple, but it was ordered as needed and not as a one-time dose. It was part of the issue with that. So it obviously didn't appear in a scheduled time on an MER slot versus an as-needed slot. And so overall, look at what caused hypoglycemia in those 57 events. Some sort of delay of the dextrose was 10% of that. Too much insulin was equal amount of that, and the insulin given the wrong route as well. Again, this doesn't add up to 100 because the other cases didn't give us enough detail to explain all that. One other thing to add now was there were also issues because of the lab value, which is interesting because, on a side note, when we did the advisory on errors with insulin, it's probably 2011, we looked at all the wrong dose errors with insulin. 13% of the wrong dose errors with insulin occurred because of wrong blood sugars at bedside. So there are mix-ups in that blood sugar value. And talk about hidden problem people aren't aware of is how blood sugars are screwing up insulin dosing because the blood sugars are wrong. So not tied into this, where almost 10% of the reports, errors occur because of the lab value issue and what was going on with them. So, for example, use of incorrect potassium value to determine treatment accounted for most of the reports. And those wrong values included a wrong patient's level. So instead of, they looked at Megan's labs and thought they were my labs instead as the example. Or in one case, it was verbally communicated as well, or it could be written as well. Some reports came back as hemolyzed, they're incorrectly reported as hemolyzed. And you know what happens, right? You get this kind of crazy high potassium level. The first instinct's going to be, this can't be right. Let's run it again. Just keep in mind, though, what's happening to the patient during this whole time period with the potentially or actually high potassium levels. One other example is that someone's creatinine value is confused for the potassium level. So you've seen the lab reports, all the values on one screen. How hard is it to pick the wrong number on that screen? And I'm going to bet money, without looking at this in front of me, that creatinine value was right above the potassium value, or vice versa, which led to the problem. So keep that in mind. Part of it, most of it's about treating the hyperkalemia, but the other part is what we're basing the treatment with. That's the lab, and things go wrong with labs. In 22% of the reports, also specifically mention improper collection techniques, where we talked earlier, where the blood specimen was taken above the site where fluids of potassium were infusing, hence throwing off the values. So the example below here, this person was on peripheral parenteral nutrition. You see the lab values here with potassium 6.2. Repeat lab was ordered per pharmacy, and well, the results were normal. Therefore, they concluded the lab drew the first set of levels from the parenteral nutrition line. However, because of the wrong value, they went ahead and treated what they thought was a high level with Kx-late insulin, and now you have to worry about hypokalemia and hypoglycemia on top of that from the whole issue with the labs. So another important consideration again is when you start solely relying on treating a number for somebody, things like this can happen. Okay, let's go to the next slide here. A little bit of discussion before we hit strategies, delayed doses. So, yeah, again, think about if you have hyperkalemia that's severe enough to cause cardiac problems. That's considered to be a medical emergency. So any delay in getting this thing started is a problem, especially when they're being postponed until the person's transferred to another unit, which, of course, is going to lead to delays in getting it. So what are you going to do now in your organization if someone gets hyperkalemia diagnosed in the ED? What are you going to do? The ED's perception probably is, well, it's not my problem. I got the next patient here. Let's just ship them off. Okay, does everyone else know that? So how is this going to be handled? What are the expectations of the ED in regard to treatment? What are the expectations of the ED in regards to communicating this to make sure it gets started immediately upon transfer to the floor? Yeah, so again, the last bullet just reiterates this. Treatment cannot be delayed. If they got levels like this high at 7 or higher, you got there's a very increased risk of cardiac arrest. So how are things going to change your organization the minute this hyperkalemia may be detected in your organization? Overdoses. Again, a lot of times in the event descriptions, it really wasn't clearly defined what led to the overdose. But they were definitely noticeable that there often people are mentioning cc's and mLs in giving insulin, which already gets me somewhat concerned because we're talking 10 units is 0.1 mLs, okay? So the minute cc and ml starts coming into play, I'm getting a little concerned because what are we using to measure this? And how much are we actually giving here? Now, there may be, I don't think it's the right way to word it. We have on here a potential lack of understanding and differences in syringes versus the fact that, listen, you got a lot of syringes up there on the floor and you grabbed the wrong syringe too, right? Because, you have regular insulin syringes that have a needle on them, epoxied on there, you can't remove the needle off. People like BD make a 1 ml insulin syringe, which I just happened to see a picture today, which also, by the way, includes ml markings on an insulin syringe, by the way, 0.1, 0.2, et cetera. And also throw on top of the fact that there may be a shortage of a Loralox syringe to give for IV push. Remember, you need the Loralox to put a needle to draw insulin out of a vial to give it IV push, which means, taking the needle back off, screwing the Loralox on to give it IV push. And keep in mind, it's 10 units. 10 units is nothing, right? So you've got to make sure it's put in something, whether it's a running normal saline line or diluted in saline to give it to make sure the insulin gets in. Because again, and this is just repeating, it has to be given in a correct syringe here. So what is available in your organization in regards to this? And this kind of stinks because besides treating hyperkalemia, when else do you need a Loralox insulin syringe? So that's the thing. So this may be the only time you use that specific type of syringe here because you're giving it IV push. So that's the big question, unless you want to order all Loralox and then attach sub-Q needles to them. So that's the catch. You're kind of stuck between the two types of syringes. Also keep in mind one thing. Some hospitals out there, they would alter insulin pens. Now, all of a sudden, you have to give insulin IV push. Well, you're not going to be using a pen to get something IV push. So what do you have around to give insulin for hyperkalemia? And how about all those nurses, the newer nurses who maybe have only used pens? Now they see this order for 10 units IV push. What do you think their first thought's going to be? This has got to be wrong. I don't give insulin IV push. It's sub-Q, right? So you got to address that situation too. Again, we may be dealing with not once in a lifetime, right? But once in a blue moon episode for people who really give this insulin that way. Okay, so discussion of hypoglycemia after giving insulin. Again, almost 30% of reports mention people getting hypoglycemia at minimum. The incidence in the literature is all over the place. I mean, holy cow. I'm almost questioning why I even have these numbers, right? When they range from 6.1 to 75%. But think about all those different iterations of treating hyperkalemia in the literature. From a different type of insulin, different doses of insulin, different amount of dextrose. Some say insulin infusion, how long is the dextrose infusion? What's the timing of giving them? Did you give, dumb question, insulin first, dextrose second? When was the dextrose given? Was it given right away or was there a delay in getting the dextrose? Talk about the type of insulin again. Is it rapid-acting insulin or regular insulin? And keep in mind the length of time that both insulins work because that will have a direct impact on the hypoglycemia. Other patient factors as well. Keep in mind, this whole topic is a temporary Band-Aid, is all it is. It's just a Band-Aid to fix the real problem, what is the high potassium level. This is a temporary fix to eventually really get the potassium out. Maybe it's dialysis, maybe it's ketoxylate, diuretics. But again, this is just a starting point, and we have to address the reasons why there may be issues. It's important to also note the hypoglycemia component that a bolus of 10 units of insulin will have a high enough concentration for maximum potassium reuptake within 20 minutes. But it's also high enough to cause hypoglycemia. In fact, really, the minute insulin starts kicking in, especially for a non-diabetic patient, always keep that in mind, that will cause a problem. Now, of course, complicating the problem is someone who has diabetes, by the way, right? So that could be another issue as well. So other things linked to hypoglycemia. Well, obviously a low dose of dextrose. how soon after dextrose is given after the bolus of insulin, and really, what was the glucose levels up front, right? If they already started off with a level of 70 or 80 because they had already eaten, is that just that time of day before lunch, their blood sugars will be low. So now you give insulin. So again, this, what sounds like a very simple procedure, is getting complicated because you have to take these other situations into control. So we'll talk about that under strategies with our standard protocol in a second here. As we said earlier, rapid-acting insulin has been shown to decrease the incidence of hypoglycemia because it has a shorter half-life. So not regular, but rapid-acting, Novolog, Humalog, quicker onset, shorter duration, it's done, right? And then go from there. In fact, you see the bottom study here, it's cited number 7 here, showed that 10 units of rapid-acting insulin, 50 grams of dextrose, only 6% had hypoglycemia. Okay, let's do strategies, and it'll be open up for questions. If anyone has any questions or comments, let us know in the Q&A box on the right-hand side. Let me just say, I think it would be great for all of us to hear how you're handling the situation now. What are your protocols state to do now? What problems are you having in your organization with this situation? Strategies. Well, listen, number one, everyone, what are your protocols? Listen, I can tell you by reading event descriptions that it was clear that organizations did not have a standardized approach how to do this. Think about what an order set and protocol would look like, because it's probably a lot bigger than you think it is, what it should entail. So, obviously, which insulin are you going to use? What's the insulin dose? How are you going to give that? What's the dose of dextrose? How long do you infuse that for? The timing of giving them? How are you going to monitor patients as well for the effects of that, both made by lab, but also just physically assessing the patient as well. So think of all the things, when are you going to draw labs next? Besides drug orders, what other things play a role in this, in your protocol? So these are some starting points that have to be standardized. So once you get the protocol in place, comes the order set, obviously. But keep in mind with the order set, build that so that you're telling people you're using this insulin and this is the dose you're using. No, you can't change it. This is the amount of dextrose you're using. No, you can't change it. And spell out so there's no way to type in wrong doses, wrong amount of dextrose. It's all laid out. And so this order set works for nursing and it works for pharmacy and physicians as well. Now, in our dream world, in a perfect world, if you have 24-hour pharmacy, I think it would be best, if possible, that pharmacy make it for you. There are other things we'll talk about in the next bullet, but we're just talking about them drawing up maybe in the pharmacy hood, in a clean room, undistracted, 10 units of insulin, then dilute that down with saline, label it, give it to the floor to give. It'll take 2 seconds to make, it'll take 30 seconds to make this, right? That would probably be the safest thing to do. Now, if you can't do that, and maybe you don't have 24-hour pharmacy, what's next? So maybe you can make a kit. And the kit will have instructions for what to do. It will include the smallest vial of insulin made on the market, which is the 3 ml vial, not a 10 ml vial. It will have the proper syringe in here and the needle to go with it on top of that. So the whole kit has, you open this little plastic box. In the box is the right syringe, the right needle, maybe an alcohol swab, the vial of insulin, a small quick hit, here's how to make this, et cetera, and then go from there. Keep in mind, we actually had someone proactively report something to Pennsylvania a little while ago about this because they ran into problems because they were putting TB syringes in the kit, and the problem with the TB syringe, even though it's the same size as the insulin syringe, the markings are different. So when someone sees 0.4 on a TB syringe, they think, oh, it's 4 units, or 1.0, which is 1 ml, is misthought of as 10 units, when it's actually a full 100 units. So that caused a problem because the TB syringe just isn't marked properly for insulin. So if you're going to use it, if for some reason you feel forced to because of a shortage, that's okay, but the instructions have to be very clear where to draw back on that syringe. That's all. Okay. Other strategies, 2 more strategy slides, and we'll get ready for questions here. Now we have on here, store insulin syringes with lower lock tips on patient care areas. Now, I'm also starting to question my strategy a little bit here too, because I don't know how much you're using these things, right? If you're only going to use these only for hyperkalemia, then I don't know if I would store any of them on a unit versus making a kit so that one syringe that you need is in there. Because think about this, unless you're going to pay the money to buy individual syringes from BD or whomever, you're going to have to buy a box of 100. What are you going to do with a box of 100 insulin lower lock syringes? And the cost and all that stuff goes in it. So just keep that in mind. Maybe you're already using them and it's fine, not a big deal. If you're using pens though, will that 1 ml syringe get confused with another 1 ml syringe? Will that cause any problems? So I'm just saying, if you go down that route, that's fine, but proactively think, okay, where are we going to store these things? Make sure they're not with other parental syringes. But that being said, make sure that people know where to get that as well. So do people know, maybe it's in the ALMA dispensing cabinet. You have one drawer for that syringe as an example, or maybe the kit is built into an EDC slot if it fits into your machine as well. Also, you require independent double checks here. Definitely for the lab, first off, is it the right person's lab? Were the results hemolyzed or not? Make sure that we are confirmed, okay, this is a problem. Keeping in mind, if you won't run a repeat lab, that's okay, but you're also losing time for that second lab draw. So, and then also get into the questionable area of, okay, do I go ahead and treat this hyperkalemia just in case, or do I wait? So that's the tough decision to make here, depending on that timing. You saw an episode earlier where it was a wrong lab, but we went and treated him for hyperkalemia when his potassium was normal. Double checks also include the type of insulin, the dose of insulin, the syringe used for the insulin, and more important, just as important, the route to be given, right? Because remember, anyone who sees an IV push order for insulin is going to get thrown off by that whole order. Lastly, for strategies, yeah, we're going to have some education about this, especially if you're going to develop a new protocol. I would even suggest a little simulation here, just even if it's the part of drawing it up and knowing how we're going to give it. Because remember, I doubt you're going to be able to draw up 10 units of insulin into a syringe and it's automatically give it IV push. It's with 0.1 mLs, everyone. I'm afraid it's going to get stuck in a line somewhere, as my old concerns with insulin and tubing and stuff like that. So I probably want to have it diluted a little bit. So keep that in mind. But again, the education should be, by the way, we may have to use a different insulin syringe. Or listen, you're used to using pens here, but for this we can't use a pen, we have to use a syringe. One example. Confirmation what the dose should be. If it's the standardized dose, everyone, like let's just say 10, then no questions asked, everyone knows it's 10. But what syringe you're going to use, how you're going to measure it, and how you're going to give it are really important things here. And by the way, this is not just for the nurses, by the way, because keep in mind, we have prescribers who didn't know how to treat this either, so this is not just a nursing issue. Doctors may be put in a position where they have to be the ones there helping treat it if someone's going under cardiac arrest. So the doc, or pharmacists are on a code team. Think of anyone who's on a rapid response team who may be involved in this. So it could be all the disciplines. So it's not a nursing alone issue. Lastly, how you monitor both glucose levels for hypoglycemia and also potassium levels as well. So keep in mind, the hypoglycemic nut set in for a little while. If you give a regular insulin, right, and you give dextrose right away, everything's fine and dandy. But the dextrose runs out, the regular insulin's still working. So someone who's not diabetic, insulin's still on board, they still could get hypoglycemia almost well after the fact. So keep that in mind. So it's going to be requiring of keeping an eye on that patient for hours after the fact. So, okay. On that note, to conclude, and we'll have questions and answers coming up in the next slide. So, look, clearly, hyperkalemia can be a very serious and even a life-threatening condition leading to cardiac arrest. It's clear, based on what we've observed in the ISMP and the Patient Safety Authority, and looking at events sent into the authority and to ISMP, that giving insulin dextrose is really important, but things can go wrong during that process because we hardly ever do it, and we don't have standardized protocols. So error is going to originate all those, including prescribing, who's making it, and where is it being made, how is it being given, and I'll throw out there how it's being monitored based on the lab values. So you need to have strategies in place to address, at least look at some of the common things that stood out to us. The delay in treatment, people getting transferred from one unit to another, wrong route issues because they're used to giving it sub-Q, not IV, overdoses because 10's kind of small, and a lot of things give you misread for 10, like 100. And also the strategies and treatments for hypoglycemia as well. So what started off as a small topic got a little bit bigger, but it's still a lot of issues to address in this whole process. So on that note, we're ready for questions if you have any. And Megan, I'll pass this over to you.
Thanks, Matt. That was really a great presentation. Lots of valuable information I think everybody can use in their organization. So that does conclude the slide presentation portion of the program. As Matt said, we are going to open it up for the question and answer period. So if you have questions, type them in the Q&A box that's found on the right-hand side of your screen and direct them to all panelists. We will try to answer as many questions as we can. And Matt, I don't see any there right now, but I actually have a question myself. I mean, that was a fabulous presentation and seriously very good information, but you were talking earlier on about potentially having some false levels of elevation when specimens are drawn above the potassium-containing IV site. And later on, then you talked about, I think you said about 10% account for some of those incorrect lab values. Not necessarily that it was drawn at the wrong place on the patient's arm or what have you, but could have been mixed up with patient names and other things. But what leveraging strategies do you see used or you would recommend to prevent this type of thing from happening? And the reason I ask that is I myself have done some like failure mode effects analysis and risk assessments with some facilities, specifically on critical values, and certainly this, obviously could be a critical value if it raises to that level. Even starting with, labeling of the specimen and drawing the specimen, that didn't bubble to the top for some of the FEMAs that I've done, but what would you recommend here as some kind of like action or strategy?
Yeah, Megan, that's a good question because I know you lived through some of this mislabeling specimen project too, and, at least, well, I guess a couple things, right? We have to figure out what specific lab issue we're talking about. So, wrong patient-wise, that comes back to the identifier issue. And really, that's in hindsight with this webinar, clearly lab has a role in this whole thing, how any specimen is being drawn. But number one, like you alluded to, is, well, how do we know what were the processes for the lab when it comes to drawing blood, especially for something like this, maybe a stat potassium level specifically, where it's being drawn from, and how it's being identified for the right patient. So both with drawing a lab and with reporting results back are the two identifiers being used. So it's not just this is Megan's potassium and Megan's medical record number is this, as an example. So we have to address the wrong patient ones that way. And I guess, Megan, it's funny because, as pharmacists and nurses here, we're not used to working with lab people. But this is kind of important because lab plays a decent role in this whole case. So we need to pull them into this, like you said, an FMEA or investigation into some of these blood draw issues because of where it actually is getting drawn. I don't know if the lab people appreciate what IVs are getting put into a line, right? And many times, many IVs may not have potassium in as well.
Yeah,
so
I think
really important. Yeah. Nursing, lab working together, and what's lab's processes in drawing stat labs that are electrolyte, like any electrolyte, not just potassium. Megan, do you have anything else to add?
No, I just think you're right. It's a team effort, and I heard you say that throughout the presentation, but I definitely echo that. You talked about the hyperkalemia order set as well, and you also talked about a hyperkalemia kit for the administration piece. Do you see order sets and kits in your travels? Is that something common?
Yeah, I couldn't tell you, Megan, how common it is. I am aware of kits. I think people, especially with rapid intubation kits, is one example that some people are going down the path of using a kit. I can't tell you the number of people that had a good standard order set for hyperkalemia, quite honestly. And I guess I get concerned too, Megan. I feel bad for all these hospitals because they do their due diligence and look at the literature and the evidence out there, they're getting conflicting messages. So that's just as much my concern. But Megan, I can't really honestly tell you if I'm seeing every hospital I've seen has them in. Often our visits, hyperkalemia is not a focus of our visits, so I really couldn't tell you how much they're being used. In fact, it'd be nice to know from the audience how many people have them or not. I really couldn't tell you. Again, I think this webinar and this topic is a classic example of the really need. I know many organizations may have a lot of standard order sets, but this is something that really, you talk about all these life-critical events when someone has a super high potassium, really, begs the question, or really presents the evidence that we need to have a good multidisciplinary team, a quick team put together to address developing these protocols, and really to get people on the phone to share with each other. Maybe some of us on the phone already have it, or have something well on its way to share with people, so maybe the authority can help in some ways disseminate what's out there in the state so we can learn and maybe, not reinvent the wheel for people.
Yeah, absolutely. Would welcome that. That's great. Great suggestion. This concludes our webinar. Thank you.